Somewhere in the world, a family is sitting in a doctor's office right now, hearing the word dementia for the first time. It's happening constantly, every single day, to people who were sharp, independent, and completely themselves just a few years earlier. And here's the part almost nobody tells them. For a real percentage of these cases, the decline didn't start with age. It started with a small bottle sitting on the bathroom shelf, something a doctor prescribed, something a pharmacy filled without a second thought, something everyone assumed was simply safe. I've spent a long time looking closely at the research on aging and the brain, and one pattern keeps showing up again and again. A handful of extremely common everyday medications, the kind sitting in millions of medicine cabinets right now, are tied to a measurably faster decline in memory and thinking in people over 60. Most people taking them have never once been warned, so today we're going through 9 of them. We're counting down from the ones that quietly slip under the radar to the one that may be the single biggest hidden driver of preventable cognitive decline in older adults. Watch for number 3 especially. It's handed out for something that sounds completely harmless, and the research on what it may be doing to memory over time is not something you hear about at the pharmacy counter. Before we start, drop a comment with your age and which of these medications, if any, you currently take. It genuinely shapes what I cover in future videos, and I read every single one. Let's start at number 9. And don't let the low ranking fool you, this one is sitting in more homes than almost anything else on this list. Number 9. Diphenhydramine, Benadryl. Number 9 is diphenhydramine, the active ingredient in Benadryl. It's the little pink pill people reach for to fall asleep, calm an allergy, or take the edge off a cold. It's cheap, it sits on an open shelf with no prescription required, and that easy availability leads a lot of people to assume it must be gentle. Inside an aging brain, it behaves very differently than the label suggests. Diphenhydramine belongs to a class of drugs called anticholinergics. That's a technical term for a simple mechanism. These drugs block a brain chemical called acetylcholine. Acetylcholine is the messenger your brain relies on to form new memories and to stay alert and focused. As we age, the brain naturally produces less of it and depends more heavily on whatever it has left. So a drug that blocks acetylcholine lands far harder on a 75-year-old brain than a 30-year-old one. The structure that takes the brunt of it is the hippocampus, the small seahorse-shaped region where new memories are first formed before being filed away for long-term storage. The research backing this up is not fringe. It comes from one of the most respected studies on this topic, published in JAMA Internal Medicine in 2015, led by pharmacy researcher Dr. Shelley Gray at the University of Washington. Her team tracked roughly 3,400 adults aged 65 and older for close to a decade, using detailed pharmacy records to calculate their cumulative exposure to strong anticholinergic drugs, diphenhydramine included. People in the highest exposure group had a 54% higher risk of developing dementia compared to those who avoided these drugs, and their risk of Alzheimer's disease specifically was 63% higher. This wasn't a small, obscure study. It followed real patients for years and controlled carefully for other health conditions. Here's what to actually do with this information. Check the label on anything you take to sleep and anything marketed as PM, nighttime, or allergy relief. A huge number of these products are just diphenhydramine wearing a different name. If you need something for allergies, second-generation antihistamines like loratadine, sold as Claritin, or cetirizine, sold as Zyrtec, don't cross into the brain nearly as easily and are considered much safer choices for long-term use. Never stop a medication on your own without talking to your doctor first, but do stop assuming that over-the-counter automatically means safe for your memory. Number 8. Proton pump inhibitors, Prilosec C, Nexium. Number 8 is a class of drugs your stomach loves and your brain may be quietly paying a price for. Proton pump inhibitors, or PPIs, include omeprazole, sold as Prilosec, and esomeprazole, sold as Nexium. They shut down acid production in the stomach and are handed out constantly for heartburn, acid reflux, and chronic indigestion. People often stay on them for years, sometimes decades, because symptoms come roaring back the moment they stop, which makes the drug feel indispensable. Here's the mechanism worth understanding. Stomach acid helps your body absorb certain nutrients from food, and one of the most important is vitamin B12, which protects the coating around your nerves and supports healthy brain function. Suppress stomach acid long enough, and B12 levels can quietly drop along with magnesium, a mineral your neurons need to fire and communicate properly. Some researchers have also proposed that PPIs may raise levels of amyloid beta, the sticky protein associated with Alzheimer's disease, though this mechanism is still being studied and isn't settled science. Now, I want to be honest with you about the evidence here because this is where the research gets genuinely mixed, and you deserve the full picture, not just the scary headline. A large 2016 study in JAMA Neurology, led by researchers in Germany, followed over 73,000 adults aged 75 and older and found regular PPI users had a 44% higher risk of developing dementia. That study got enormous media attention. But several later analyses, including a meta-analysis pooling more than 640,000 patients, found no significant overall link between PPIs and dementia risk once other health factors were accounted for. Some studies even found the opposite. The honest summary is this: the evidence is inconsistent, the effect, if it's real at all, appears strongest with very long-term high-dose use in the oldest patients, and no major medical body currently recommends stopping a PPI purely out of dementia concern. That said, PPIs do have other well-established long-term risks, including nutrient deficiencies, bone fracture risk, and kidney issues. So if you've been on one for years without a clear ongoing reason, it's worth a conversation with your doctor. Many people can safely step down to a gentler class called H2 blockers, like famotidine, sold as Pepcid, or manage symptoms with lifestyle changes. The goal, as always, is the lowest effective dose for the shortest necessary time, not a pill taken forever out of pure habit. Number 7. Oxybutynin, ditropan. Number 7 is prescribed for a problem a lot of people would rather not discuss out loud. Oxybutynin, sold under the brand name ditropan, is given to people dealing with an overactive bladder, that sudden, urgent need to find a bathroom that can reshape an entire day. The relief it provides is real, and so is the dignity it restores. But oxybutynin works by blocking acetylcholine, the exact same memory-related chemical that diphenhydramine blocks, and it crosses into the brain quite readily. This drug was actually one of the specific medications tracked in that same 2015 JAMA internal medicine study I mentioned earlier. Oxybutynin was among the most commonly used strong anticholinergics in the entire dataset, alongside diphenhydramine and a tricyclic antidepressant we'll get to shortly. People taking meaningful doses of oxybutynin for more than a few years fell into that same higher risk exposure group tied to a 54% increased dementia risk. The frustrating part is how often this connection goes unmentioned. People are told a pill will calm their bladder. Nobody explains that it may also be dimming their memory at the same time. Families quietly chalk up the forgetfulness to normal aging, when the real driver may be sitting in the pill organizer. If you take oxybutynin and you've noticed your memory slipping, that's worth raising with your doctor, because you don't have to choose between bladder control and brain health. Newer medications like mirabegron, sold as Myrbetriq, work through a completely different pathway that doesn't touch acetylcholine at all, and they offer similar symptom control for many older adults with far less cognitive risk. It's a conversation worth having at your next visit. Number 6. Statins. Number 6 might surprise you because it's one of the most widely prescribed medications on the planet. Statins, including simvastatin, Zocor, and atorvastatin Lipitor, lower cholesterol and reduce the risk of heart attack and stroke. They save lives, and this is absolutely not an argument against taking one if your doctor has prescribed it for a real cardiovascular reason. But there's a part of the story that rarely gets mentioned. Your brain is nearly 60% fat, and it relies on cholesterol to build myelin, the insulating sheath wrapped around nerve fibers that let signals travel quickly and cleanly. Here's where I want to be very upfront with you. The science on statins and cognition is genuinely one of the most contested areas in this entire list. In 2012, the FDA added a label warning about reports of notable but ill-defined memory loss that appeared to be reversible once people stopped the medication, meaning short-term fogginess, not permanent dementia. Some smaller studies raised concern about a link to long-term cognitive decline. But larger, more rigorous studies tell a different story. A major analysis of nearly 19,000 older adults followed for over 4 years, published in JAMA Internal Medicine's family of journals, found no significant association between statin use and incident dementia or measurable cognitive decline. Major cardiology and geriatric bodies currently conclude there isn't enough solid evidence to say statins meaningfully harm long-term brain health, and 2 large ongoing randomized trials, STERI and Preventable, are specifically designed to settle the question once and for all. What we do know is that statins differ in how easily they cross into brain tissue. Lipophilic statins like simvastatin and atorvastatin cross more readily than hydrophilic ones like pravastatin and rosuvastatin. If you're on a statin and you notice brain fog, that's a reasonable thing to mention to your doctor. A lower dose or a switch to a different statin may help. But this is not a case where you should stop a heart protective medication on your own out of fear. Stopping a statin carries its own well-documented risk, more heart attacks and strokes themselves are one of the leading causes of vascular dementia. Get the plan right with your doctor, not with a Google search at midnight. Quick pause, if this is helping connect some dots for you, tap that like button. It genuinely helps this information reach more people who need to hear it. And while you're there, tell me in the comments how many prescriptions you're currently managing. All right, back to the countdown. Number 5, benzodiazepines, Ativan, Valium, Xanax. Number 5 is the benzodiazepines, lorazepam, Ativan, diazepam, Valium, and alprazolam, Xanax. These are among the most commonly prescribed medications in the country for anxiety and sleep problems. They work by boosting GABA, the brain's natural calming signal that quiets an overactive nervous system. At first, they can feel like a genuine rescue, the panic eases, the racing thoughts slow, and sleep finally arrives. The research on long-term use and dementia risk is real, but I want to give it to you with the appropriate nuance because headlines have oversimplified it. Several meta-analyses pooling dozens of studies and hundreds of thousands of patients have found benzodiazepine users have somewhere between a 30 and 78% higher relative risk of developing dementia, depending on which analysis you look at. But researchers openly acknowledge a major complication called reverse causation. Early, undiagnosed dementia often causes anxiety and sleep disruption in the first place, which is exactly what leads doctors to prescribe a benzodiazepine. So some of that statistical link may reflect the medication being prescribed for early symptoms of a disease that was already quietly starting, rather than the drug causing the disease itself. Some of the highest quality recent studies, when they control carefully for this, find the association shrinks or disappears entirely. What's not in dispute is the sedation, the fall risk, the slowed thinking, and the emotional flatness many people describe while taking these medications regularly, and the genuine danger of stopping abruptly. If you've been on a benzodiazepine for more than a few weeks, do not stop suddenly. Abrupt discontinuation can cause severe rebound anxiety, insomnia, and in some cases dangerous withdrawal symptoms. Work with your doctor to taper slowly over weeks or months if you and your doctor decide it's the right move. Gentler long-term options exist. Buspirone can help with anxiety without the same sedation, and specialized forms of cognitive behavioral therapy for insomnia and anxiety can restore calm without the same trade-offs. Number 4, amitriptyline, Elavil. Number 4 is a single medication prescribed for 3 very different problems, and it carries one of the heaviest hidden burdens on this entire list. Amitriptyline, sold as Elavil, is an older tricyclic antidepressant still widely prescribed today for nerve pain, sleep difficulty, and migraine prevention. That versatility is exactly why it stuck around. It looks like a medication that can do everything. But underneath that versatility, amitriptyline is one of the most powerfully anticholinergic drugs still in common use. It blocks acetylcholine so strongly that with sustained use, memory problems stop being a rare side effect and start looking like an expected outcome. This drug wasn't a footnote in the research, it was one of the primary medications tracked in that landmark 2015 Gray et al. Study. Along with diphenhydramine and oxybutynin, tricyclic antidepressants like amitriptyline made up the bulk of the strong anticholinergic exposure that was tied to that 54% higher dementia risk and 63% higher Alzheimer's risk in the highest exposure group. And it doesn't necessarily take a high dose, a small nightly dose, taken consistently for years, can add up to significant cumulative exposure. If you or someone you love takes amitriptyline, that's a conversation worth having soon. For nerve pain, alternatives like duloxetine or gabapentin may offer similar relief without the same anticholinergic load. For sleep, melatonin or a very low dose of doxepin, which has a much gentler effect on this particular chemical pathway at low doses, may serve as options. For mood, newer antidepressants like sertraline or escitalopram are generally considered far safer for long-term brain health. Always make these changes with your doctor, never on your own. Number 3, paroxetine, Paxil. Number 3 is the one I told you to watch for because it's prescribed to millions of people for something that sounds completely harmless. Paroxetine, sold as Paxil, is a widely used member of the SSRI family of antidepressants, prescribed for both depression and anxiety. On the surface, SSRIs look like the gentle, modern alternative to older psychiatric medications. But here's the detail that rarely comes up. Paroxetine has meaningfully more anticholinergic activity than almost any other SSRI on the market. Sertraline and escitalopram, for comparison, have very little. That single property sets paroxetine apart and connects it to the same acetylcholine blocking pathway responsible for much of what we've already discussed today. This isn't a fringe concern. It's well documented enough that the American Geriatric Society includes paroxetine on the Beers criteria, a formal, widely used list of medications considered potentially inappropriate for older adults, specifically because of this kind of risk. Several studies looking at cognitive performance in older SSRI users have found paroxetine associated with more noticeable effects on short-term memory and attention compared to other SSRIs in the same drug class. There's a real irony here. The medication is prescribed to stabilize someone's mental state, and yet in older adults, long-term use may work against the very clarity it's meant to protect. If you're taking paroxetine, it's worth asking your doctor whether switching to a lower anticholinergic SSRI like sertraline or escitalopram makes sense for you. These alternatives are generally considered gentler on cognition while still treating depression and anxiety effectively. Number 2. Antipsychotics, Seroquel, Risperdal, Zyprexa. Number 2 is prescribed so quietly that many people taking it don't fully realize what class of medication it belongs to. Quetiapine, Seroquel, Risperidone, Risperdal, and olanzapine Zyprexa were originally developed for serious psychiatric conditions like schizophrenia and bipolar disorder. Today, they're frequently used off-label in older adults for sleep problems, restlessness, or the agitation that can come with dementia itself, a use they were never actually approved for. This is one of the most firmly established risks on this entire list, not a debated one. In 2005, after reviewing 17 placebo-controlled clinical trials, the FDA issued its strongest possible warning, a black box warning, stating that elderly patients with dementia-related psychosis who take these drugs face a 1.6 to 1.7 times higher risk of death, primarily from heart-related events and stroke. In 2008, the FDA extended that same black box warning to older first-generation antipsychotics as well, after further research showed comparable or even higher mortality risk with those drugs too. This warning applies across the entire class. Beyond mortality, these medications work by suppressing dopamine, a chemical involved not just in mood but in focus, planning, and memory. Reduce dopamine activity enough and the brain can become slower and less responsive, which is part of why some people on these medications appear unusually flat or withdrawn, even when a family member's underlying dementia hasn't actually progressed that much. If you or a loved one is taking one of these medications for sleep or agitation rather than a primary psychiatric diagnosis, the first question worth asking the prescribing doctor is simple: why was this started, and is it still necessary? Many behavioral symptoms in older adults can be meaningfully improved through non-drug approaches first: consistent routines, reduced overstimulation, treating underlying pain, and improving sleep environment. When medication truly is necessary, the lowest effective dose for the shortest possible time is the standard of care. Number 1. Anticholinergic polypharmacy. And now, number 1. It isn't a single drug at all, and it may be the biggest hidden driver behind nearly everything we've covered today. Number 1 is anticholinergic polypharmacy, the slow, unnoticed stacking of multiple anticholinergic medications taken at the same time. You might have been expecting one final villain, one single worst pill. The reality is more subtle and honestly more common. Picture a very realistic scenario. Someone takes diphenhydramine nightly for sleep, oxybutynin daily for their bladder, and amitriptyline for nerve pain. Individually, each medication might seem to cause only a small, barely noticeable effect. Together, those effects don't just add up, they compound, because they're all blocking the same acetylcholine pathway from different directions at once. This is exactly the mechanism behind that landmark 2015 study we've returned to throughout this video. The people in the highest cumulative anticholinergic exposure group, meaning the equivalent of taking a strong anticholinergic medication daily for 3 years or more, had that 54% higher risk of dementia and 63% higher risk of Alzheimer's disease specifically, compared to people who used little or none. And the researchers were clear about something important. At the time, most participants had no idea they were even taking anticholinergic medications, let alone stacking several of them together. No one had ever added it up for them. Here's the genuinely hopeful part, and it's the reason this topic matters so much. Some cognitive effects from anticholinergic medications appear to be at least partially reversible when the burden is identified and reduced early, particularly for effects like reaction time and attention, though once dementia has fully developed, the picture is far more complicated. The brain has real capacity to recover from a chemical burden, but only once that burden is actually recognized and addressed. The solution here doesn't require anything dramatic. It requires one focused conversation. Sit down with your doctor or pharmacist and review every prescription medication, every over-the-counter product, and every supplement you take. Ask directly, does anything on this list have anticholinergic activity? And if so, is there a safer alternative? Pharmacists in particular are trained to calculate something called anticholinergic burden, and many clinics can run a formal review in a single visit. Once problem medications are identified, they can often be reduced, switched, or eliminated under proper medical supervision, giving the brain a real chance to recover some of what may have been quietly lost. Of the 9 things we covered today, I want to hear which ones are sitting in your medicine cabinet right now. Have you or someone you love noticed brain fog or memory changes after starting a new medication? Tell me in the comments, and if this was useful, tell me you'll bring up a full medication review at your next appointment. Somebody reading the comments after you might need to see that. Before you go, your medicine cabinet is one place your body hides its warning signs. It's not the only one. Your fingernails can quietly reveal early signals related to your kidneys, your blood, and even your nervous system, often years before other symptoms show up. Most people never learn what to actually look for. That's exactly what we're covering in the next video, 4 nail signs worth checking tonight.